Hello friends. Today we're going to discuss about an important atypical antipsychotic, that is cariprazine. In this video I'll be discussing about the structure, the history behind the discovery of cariprazine, mechanism of action, pharmacokinetics, dosing, and indication of cariprazine will be discussed in this video. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about the history, mechanism of action, side effects, dosing, and indication of cariprazine. Let's understand how the cariprazine was discovered. It was developed by a scientist called as Gideon Richter. He was a scientist from Budapest in Hungary. During his scientific research, by accident, he found one molecule. During these biosynthetic experiments and manufacturing of another compound, Gideon Richter identified an impurity known as 2M. And this 2M was more effective than the targeted molecule what they wanted to manufacture. So in this, you can clearly say Gideon Richter wanted to target some molecule and he was trying to isolate it. During that time, he came up with an impurity called as 2M. Later, it was called as RGH188 because this impurity 2M was considered to be very pivotal. The later part, considering that this molecule played a crucial role in antipsychotic activity, my dear friend. That means the discovery of cariprazine was by an accident, and it was a nice accident, my dear friends. Although 2M is considered to be an anomaly and a impurity, later it has been found to be very effective in treatment of psychosis. Further, this 2M, so-called contaminant, possessed a therapeutic potential in treatment of psychosis. Hence, this was renamed from 2M to RGH188. And this molecule had an excellent blood-brain permeability and also promising safety profile in early test. Hence, this RGH188 was subjected to various clinical trials. Hence, later this RGH188 was subject to various important clinical trials for various psychiatric disorders like schizophrenia, bipolar 1 disorder, and also in depression. And finally, in 2015, FDA approved for schizophrenia and bipolar 1 disorder. Later in 2022, the US further expanded the use of cariprazine as an adjuvant treatment for major depressive disorder. Further in 2017, Canada and Europe also approved cariprazine for the treatment of schizophrenia. And also in 2020, Australia said that this cariprazine is found to be effective in schizophrenia and it approved there. You can see the way cariprazine evolved. And finally, in 2015, the FDA approval came for schizophrenia, European Commission, and then FDA in 2019, 2022 for major depressive disorder. And this is how you can see the cariprazine started from schizophrenia in US, Europe, and FDA again in 2019 and 22 for major depressive disorder. This is how the milestone of cariprazine can be understood. Now let's look into the chemical structure. It is a piperazine derivative, my dear friend. It is distinguished from other antipsychotics like typical antipsychotic by its unique interaction with the dopamine receptor. It's functioning as a partial agonist for D3 receptor rather than being a pure antagonist, my dear friend. Invariably, antipsychotics are considered to be D2 blockading, and hence positive symptoms gets improved. Whereas in cariprazine, my dear friend, it was a partial agonist. Let's look into the mechanism of action of cariprazine. As I mentioned, the typical antipsychotic, you can see here the dopamine which are there will act on D2 receptor. Hence, the antipsychotics, which are marked in yellow, will block the D2 receptors. These antipsychotics are typical antipsychotics. So the primary target of a typical antipsychotic or a standard antipsychotic is blocking D2 receptor. Hence, by the mechanism of blocking D2 receptor, the positive symptoms like delusions, hallucinations are decreased. But however, cariprazine has a different mechanism of action. You can see here the dopamine again wants to act on D2 and D3 receptor. But however, similar to dopamine, you can see cariprazine also is there. However, this cariprazine has a 10-fold higher affinity toward D3 receptor than compared to D2 receptor. That means one of the important differentiation from standard antipsychotic is its cariprazine has higher affinity towards D3 receptor than D2 receptor. Further, it occupies D2 receptor, and not only that, it occupies in competition with the dopamine. That means the affinity versus endogenous dopamine versus cariprazine has further higher occupancy rate. By this means, you can see in the diagram, dopamine will be dislodged and cariprazine will occupy D3 receptor, my dear friends. That means in competition with endogenous dopamine. This is one of the important mechanism of action. Further, it has a partial agonism with regard to 5-HT1A and antagonism with 5-HT2B. Minimal activity with H1, that is histaminic and muscarinic receptors. Let's look into all of these once again. Cariprazine has highest affinity towards dopamine 3 receptor. When compared to D2, it is 10 times more affinity towards D3. While most atypical antipsychotics are partial agonist or antagonist at both D2, D3, cariprazine is unique because it possesses 10-fold affinity for D3 than D2 receptors. Its potency for D3 receptor is actually higher than the endogenous dopamine, which I said, making this only antipsychotics capable of blocking D3 receptor in the human brain, my dear friends. Even in the presence of dopamine, D3 receptors are occupied by cariprazine. You can see here clearly, invariably all antipsychotics target D2, function is in the striatum and controls motor symptoms, and as a function, further it has a side effects. By blocking D2, it improves psychotic symptoms. However, in cariprazine, my dear friend, it acts on D3 and the high affinity for D3, whereas which occurs in more D3 receptors are more commonly seen in ventral tegmental area and limbic system. Why this is very essential? Because it modulates mood, cognition, and reward pathway. This reward pathway plays an important role, especially in substance use. Hence, not only improvement in positive symptoms, negative symptoms, cognitive symptoms, depressive symptoms, but also as an anti-craving agent, my dear friends. So cariprazine becomes a trans-diagnostic medication, that means broad spectrum. Further, it also has 5-HT1A receptor partial agonist. That means cariprazine binds to these receptors with high affinity. Further, the partial agonism with 5-HT1A receptor contributes to antidepressant, anxiolytic, and pro-cognitive effect. That means it improves cognition. Further, it reduces extrapyramidal side effect by being partial agonist at 5-HT1A. It also has a strong antagonism with 5-HT2B receptor and moderate antagonism at 5-HT2A receptor and low affinity for 5-HT2C receptors. See, here you can clearly understand 2B, 2A, 2C, 5-HT. Strong with the 2B, moderate with the 2A, low affinity for 2C. So this also plays a role in lesser side effect, improvement in cognition, improvement in negative symptoms, and antidepressant activity. It also has moderate antagonism with H1 receptor. This causes mild weight gain. Various clinical trials says that if you give for over a period of 3 to 6 weeks, maximum 1 kg weight gain can occur. Further, high affinity for alpha-1b receptor, which may be linked to reduced extrapyramidal side effect. It has negligible activity at the cholinergic, especially muscarinic receptor. Hence, it does not cause us sedation, or else it does not cause us dry mouth. Further, cariprazine has a low affinity for opioid receptor, glutamate, and GABA receptor. However, it binds with high affinity for D3, as I mentioned earlier, moderate affinity for sigma-1 receptor. This sigma-1 receptor and D3 receptor may play an important role in substance use. That means if a person with schizophrenia or bipolar disorder with comorbid substance use, cariprazine can be considered because it acts both on psychosis, bipolar disorder, but also in comorbid substance use. Here you can clearly see it has a high affinity for D3 receptor, that is picomolar affinity. This dopamine having more affinity towards D3 compared to D2 plays an important antipsychotic role. And further, this having higher affinity towards D3 also competes with endogenous dopamine. It also acts on serotonin, that is partial antagonism with 5-HT1A and antagonist at 2B and 2A receptor. Further, low affinity for H1 and alpha-1 adrenergic receptor results in low risk for sedation, metabolic syndrome, and orthostatic hypotension. Now let's look into the pharmacokinetics. Cariprazine is rapidly absorbed after oral intake. It reaches peak plasma level within 3 to 6 hours. Its absorption is not significantly affected by food. That means whether it is taken orally or empty stomach or with food, it does not have major effect. It is metabolized in liver by CYP3A4 isoenzyme, my dear friend. This metabolism produces two important metabolites. One is desmethyl cariprazine, it is called as DCAR. Another metabolite, didesmethyl cariprazine, DDCAR. Cariprazine itself has half-life of 2 to 6 days. Active metabolite DCAR and DDCAR has a half-life of 1 to 3 weeks, my dear friend. It takes approximately 4 to 8 weeks of daily dose of cariprazine to reach a functional steady state. This is very essential to understand, my dear friend. Here, I'll show you cariprazine. The molecule which is taken has a half-life of 2 to 4 days. Every day if they take, it takes steady state to reach in plasma maximum 2 weeks. That is only cariprazine. But unfortunately, once the cariprazine is taken, there is a CYP3A4 isoenzyme in the liver. It divides into two metabolites, active metabolites they are. One is active metabolite DCAR, which is called as desmethyl cariprazine. Another one is didesmethyl cariprazine, DDCAR. DCAR has half-life of 1 to 2 days. Steady state, it requires 2 weeks. That is similar to cariprazine. But however, my dear friend, DDCAR, that is didesmethyl cariprazine, has a half-life of 1 to 3 weeks, and steady state to reach it requires 4 to 8 weeks. This 4 to 8 weeks has various implications. That means the side effects can be delayed up to 6 to 8 weeks because this DDCAR may accumulate over a period of time. At the end of 2 months, you can see side effects, maybe akathisia or EPS. Hence, you may not see the side effects immediately, but it may appear at the end of 2 months. Now let's look into the cariprazine availability in India and cost. Cariprazine is available as in a capsule, as 1.5 milligram capsule, 3 milligram, 4.5, 6 milligram. So the maximum dosage is 6 milligram. These are the availability. The approximate cost of 1.5 milligram is 10 rupees. 3 milligram one capsule 20 rupees. 4.5 milligram capsule is 30 rupees and 6 mg capsule is 40 rupees, my dear friend. This is available as capsule. These are all denominations are available in India. Now let's look into the indication and dosing. The recommended dosage for schizophrenia as per FDA approved, start with 1.5 milligram, reach maximum 6 milligram per day. Since the half-life is 1 to 2 days, my dear friend, single OD dosage in the night is more than enough. Bipolar 1 disorder, either for manic or mixed episode, 3 to 6 milligram per day. Bipolar disorder, depression, 1.5 milligram to 3 milligram. For depression, the dosage is less. For as manic and mixed episode, the dosage is 3 to 6 milligram. For major depressive episode, it has been approved as an adjuvant treatment with antidepressant, dosage of 1.5 to 3 milligram. The adjuvant antidepressant invariably, escitalopram, sertraline, fluoxetine can be given. What about the cariprazine in dual diagnosis? D3 receptor are concentrated in limbic area and in the brain, such as ventral tegmental area and nucleus accumbens. This limbic area, ventral tegment area, and nucleus accumbens, these are the regions responsible for mediating motivation, emotion, reward pathway. That means this VTA, nucleus accumbens, and limbic area are important for substance abuse, maintenance of addiction, motivation. Hence, cariprazine acts on these D3 receptors which are present in this area, and this preferring D3 partial agonist, and it is high potency towards D3 receptor, works so beautifully. It competes with endogenous dopamine. By competing with endogenous dopamine, it blocks the dopamine. By blocking this, it decreases the kick or the surge or the euphoria effect of these drugs. So, my dear friends, D3 receptor preferential partial agonist, which is 10 times more than the dopamine itself, affinity, this triggers an important mechanism of decreasing the craving and working in substance abuse also. Further, in the real world, the patient does not come just with schizophrenia or bipolar disorder or just a depression. They invariably have dual diagnosis. They will have either alcohol use, nicotine dependence, cannabis dependence, or cocaine dependence, or combination of all these. Hence, in the real world scenario, the patients invariably with schizophrenia or BPAD will usually come with substance use. In such a scenario, giving cariprazine plays an important role, not only controlling psychosis but also substance use. So, my dear friend, substance-induced psychosis and mood disorder, various clinical trials have found that it has been found to be useful. Hence, it is considered to be a trans-diagnostic molecule, my dear friend. Hence, nowadays there are studies which are pouring in, open label trial, with regard to dual diagnosis. Not only that, cariprazine also has been advocated in treatment-resistant schizophrenia, especially augmentation. Here, if a patient is with the treatment-resistant schizophrenia on clozapine and still he has symptoms, it may be negative symptoms, it may also have apathy or cognitive dysfunction or asocialization. In such a scenario, along with clozapine, adding an augmentation of cariprazine, 1.5 milligram up to 3 milligram we can give. In such a scenario, combination of clozapine and cariprazine has an important effect, and it has been found to be helpful in treatment refractory schizophrenia, my dear friends. What about cariprazine in pediatrics? Invariably, FDA has approved cariprazine for children for bipolar disorder from 10 to 17, for schizophrenia 13 to 17 years. The dosing for children that is below 18 is between 1.5 to 4.5 milligram, my dear friend. And it has been found to be effective. So bipolar disorder 10 years and above, schizophrenia 13 years and above, the dosage is between 1.0 to 4.5. It also has been approved for autism spectrum disorder. The age from 5 to 17 years, my dear friends. In autism, where the patient has maybe having behavioral problems, psychotic symptoms, in such a scenario, cariprazine can be started at the dosage of 0.5 and we can build up to 3 milligram per day. So cariprazine also works in autism spectrum disorder to bring down the behavioral problems. However, whenever we are using in pediatric, we need to be very careful and we need to monitor the weight gain. Especially in children with autism spectrum disorder, it has found to cause some weight gain. Hence, we have to track the BMI. Not only that, it can alter hepatic function, especially alanine transaminase. We need to look at this and see whether there is an increased appetite. In such a scenario, if there is any hike in alanine transaminase more than 10 times, we may have to bring down the dosage. Further, in children, it can cause dizziness and restlessness. We need to monitor this in children. So, my dear friends, in the age of 5 to 18 years, and specifically at the age of 5 to 10 years, we need to monitor the BMI when we are giving cariprazine, especially in autism patients, and we need to monitor the enzymes of LFT. What about in pregnancy and lactation? Currently, we do not have studies with regard to cariprazine in pregnancy. That means there is an evidence gap. We don't have information at all, my dear friends. Further, we do not have any information whether it is secreted in breast milk or not. Hence, since there is evidence gap, do not prescribe cariprazine in a pregnant woman or else if she is breastfeeding. Further, what about giving cariprazine in a woman with a childbearing age? She is recently married, she is planning to have a child. Should we give? That's a very important. We need to discuss with the patient. Tell them we do not have information with regard to cariprazine in pregnancy. We may have to change it. Or else do not start cariprazine. Further, cariprazine is frequently and safely co-administered with lithium and lamotrigine for bipolar management. But however, if they are planning for pregnancy, do not give cariprazine, my dear friends. Further, we need to be very careful when we are giving cariprazine along with valproic acid, especially in childbearing age. This can cause a severe teratogenic effect on the child or the fetus. Hence, we need to counsel the patient and the spouse with regard to cariprazine, childbearing, pregnancy, and lactation. So we have to weigh the risk versus benefit. Then only we would to give cariprazine. I would rather recommend do not give cariprazine in a childbearing age woman who is planning to have pregnancy. What about the neonatal risk? By chance, there is an accidental exposure of cariprazine. If the child is born, the fetus, if there is exposure for the fetus is there is a high risk of neonatal developing EPS if cariprazine was administered to mother. So we have to keep an eye on this. We need to discuss with the pediatrician, neonatologist. This may have an effect on feeding, child immediate growth. So we have to be very careful. EPS may develop in child. Further, the neonatal also may face, suppose imagine the patient was on cariprazine and once the child birth occurs, the neonatus may face severe withdrawal symptoms post-delivery, require intensive monitoring of the child. So, better to avoid cariprazine in third trimester. And if it is there, we may have to switch over to other medication. What about geriatric population? Again, we do not have much information with regard to geriatric usage, but however, there is a black box warning. As for any other antipsychotics, even cariprazine has a core warning telling that it causes increased risk of dementia-related psychosis and sudden death. Hence, invariably when we give antipsychotics in a geriatric patient, we need to weigh the risk versus benefit because of sudden cardiac arrest or mortality is very high. What about cardiovascular? High incidence of fatal cerebrovascular accidents have been noted with antipsychotics, even trans-ischemic attacks. Transient ischemic attacks also is known, but however, they are rare, but you need to keep a watch and you have to inform the patient. Further, cariprazine is also known to cause susceptibility to systemic infections. Again, these both systemic infection and cardiovascular accident with cariprazine, especially in elderly, is a rare, but we have to be cautious. Hence, the evidence gap is there with regard to cariprazine. That means after the age of 65, we do not have any RCTs majorly comparing with other antipsychotics. So systematically conducted studies are very less. The evidence gap is there. What about the clinical advantage? Since it has a less effect on muscarinic receptor, H1 receptor, so anticholinergic side effects are less. No confusion, no urinary retention, no excessive sedation. However, if you want to give cariprazine, start low, go slow. Start low means start less than 0.5 milligram and go slow. Go slow means increase very slowly if it is required. Otherwise, avoid cariprazine. To summarize cariprazine, my dear friends, the evidence level for adult is robust. It is given in schizophrenia and bipolar disorder. The dosage for schizophrenia is 3 to 6 milligram, my dear friends. In bipolar disorder, the dosage will be around 3 milligram. Akathisia and EPS is a biggest challenge. In pediatric, my dear friend, the trials are slowly emerging now. The dosage is between 0.5 to 4.5 milligram. It has been approved for schizophrenia. Nowadays, even for autism spectrum disorder. With regard to geriatric, the evidence is lacking. But however, if you want to give cariprazine, start low, go slow. Invariably keep an eye on stroke, transient ischemic attacks, and dementia-related mortality. What about pregnant? There is no data available, my dear friends. So avoid giving cariprazine in third trimester or breastfeeding women. What about the safety and side effect profile, my dear friend? The most common side effect of cariprazine is akathisia and extrapyramidal symptoms. Both are dose dependent, my dear friends. Other side effects are insomnia, nausea, vomiting, restlessness, and constipation. Although constipation are less because it does not act on muscarinic receptor, that is anticholinergic side effects are less, but still it can cause. Cariprazine is associated with low rates of weight gain, minimal prolactin elevation, and no significant QTC prolongation. These are the benefits, my dear friend. That means no weight gain, prolactin elevation is very minimal, and no QTC prolongation. Again, you can see here with regard to cariprazine at the dosage of 1 to 5 milligram, 1.5 milligram to 3 milligram, akathisia is 20%. At 12 milligram, it becomes 23%, my dear friend. With regard to EPS, it is 11%, 3 milligram. At 6 to 12 milligram, it becomes 14%. Nausea vomiting, 9% and becomes 11%. That means nausea vomiting is not dose dependent. Only akathisia and Parkinsonism are dose dependent. Hence, we have to be very careful, my dear friends. Now let's talk about akathisia, which is a very disturbing side effect. Invariably, once the patient is started on cariprazine, 15 to 20% of the patient may develop akathisia. It is strongly dose dependent, hence start low and go slow. Invariably, akathisia can be seen in the early onset or late onset. Let me talk about this. Early onset means as soon as you start, within a week, you can see akathisia. That means as a cariprazine. Late onset, that is dysmethyl Cariprazine, my dear friend, which accumulates over a period of 3 to 6 weeks. Late onset, that is after 6 weeks, the patient may develop akathisia. Hence, we have to be open and you have to observe not only immediately, but also after 6 weeks. Further, the maximum akathisia are mild, 54%, moderate is 43%, severe is 3%. Invariably, keep an eye, and if they require, you may have to add invariably propranolol or benzodiazepines. To manage agitation and insomnia, because cariprazine lacks H1 sedation and acute agitation requires adjunct medication, my dear friends. That means since it does not cause any insomnia, we have to give temporary lorazepam or else a trazodone. Lorazepam can be 0.5 milligram to 1 milligram. Trazodone can be even 25 to 50 milligram, my dear friends. So for managing agitation and insomnia, cariprazine invariably require lorazepam. For managing akathisia, invariably it occurs in 22 to 25%. Be slow in titration. Give very low dosage, 1.5 milligram. Increase every 3 days or monthly, or maybe weekly, sorry. If required, add a beta blocker or trihexyphenidyl. Best is a beta blocker. If akathisia persists, you may have to reduce the dosage or change over to other medication which has the lowest akathisia, like brexpiprazole, my dear friends. Now let's look into the integration table. That is, how do we consider and when does the akathisia occurs? You can see here, my dear friends, weeks 1 to 3, week 4 to 6, and week 7 to 8. Invariably, the yellow line. What happens here? Whenever the old drug, for example, the patient is on olanzapine and it is slowly tapered and we are trying to introduce cariprazine. We are decreasing the dosage of olanzapine over a period of 2 months. That is the yellow line. Now, when we add a cariprazine, suddenly the cariprazine serum level increases. So within 1 to 3 weeks, within the 1 week, the akathisia may pick up. Not only that, lower dysmethyl cariprazine accumulates over a period of 4 to 8 weeks. At the 4 to 8 weeks, again, there is a possibility of akathisia. So that you need to understand. First 1 week and last 4 to 8 weeks is the highest chance of developing of akathisia and EPS. So we have to be very careful and focus on that. Let's compare the side effect profile of cariprazine with other atypical antipsychotics. Here you can see cariprazine is compared with brexpiprazole, aripiprazole. With regard to akathisia, cariprazine scores very high. Invariably it is 14% they are mentioned, but nowadays the studies have shown up to 20%. So you have to keep an eye. With regard to weight gain, insomnia, sedation, it is very less, my dear friend. With regard to brexpiprazole, the akathisia, weight gain, insomnia, sedation is very, very minimal. For that reason, my dear friend, brexpiprazole has a better side effect profile than cariprazine. With regard to aripiprazole, akathisia is almost similar with cariprazine, whereas weight gain and insomnia and sedation, they are mild. So, cariprazine limitation is akathisia and EPS. Otherwise, it is similar to brexpiprazole and aripiprazole. Invariably, akathisia and EPS limits the use of cariprazine. Whatever the blood investigation required, there is no specific blood investigation is required. However, the manufacturers talk about periodic monitoring of weight gain, blood glucose and lipids. First, you need to do the baseline, and every follow-up, please check for the weight, blood glucose and lipids. Further, you may have to keep an eye on the hepatic function and renal function. Further, invariably, if the patient develops EPS or metabolic syndrome, you need to keep a watch on that and monitor cariprazine and any other concomitant drug is given. Let's look into this cariprazine titration. Now we have understood the cariprazine, how it is given, what is the dosage. Invariably, cariprazine is given in 2 types. One is fast inpatient, slow titration outpatient. Let's look into the fast inpatient What is the dosage? How it is given? Every day, increase 1.5 milligram till we reach 6 milligram. First day, 1.5 milligram, OD in the night. Second day, 3 milligram. Third day, 4.5 milligram. And fourth day, 6 milligram. Because the patient is inpatient, observe for the side effects, and manage and monitor. That means every day increment of 1.5 milligram. By the end of 1 week, you are at the highest possible dosage. What about outpatient? Be slow in titration. Invariably on outpatient, the patient being a bipolar disorder or schizophrenia, increase 1.5 milligram every 2 weeks. So that slow outpatient increment. Even for maintenance, give slow and go low medication, my dear friends. So these are the two possible ways of titration. Now the question is there any rebound effects? That is how we start. Suppose you are giving another medication and you need to introduce cariprazine and you have to remove the other medication. Imagine if you are giving a patient with risperidone and it does not improve. Now, if you want to introduce cariprazine, how will we do? Is there any rebound effects? Yes. For example, here we are discussing about legacy rebound effect. We note how we should not confuse with the cariprazine side effect, because here, imagine we are giving dopamine blocker, D2 blockade. A strong D2 blockade can be a risperidone, haloperidol. And you are giving them and you suddenly stop D2 blockade and start cariprazine. Imagine you have blocked it and cariprazine has a D3 partial agonist and does not act on D2 blockade. Suddenly there will be a dopaminergic rebound risk, my dear friend. Hence, there will be worsening of positive symptoms immediately, and you should not confuse with the cariprazine causing psychosis. It is called as dopaminergic rebound risk, my dear friend. Suppose if you are giving a medication like olanzapine, which has antihistaminic side effect, and suddenly if you stop olanzapine, since cariprazine does not have anticholinergic side effects, there can be antihistaminic rebound effect. Insomnia, agitation, anxiety can occur. This also should not be confused with cariprazine side effect. It is we have giving olanzapine or quetiapine, and that suddenly stoppage can cause. Further, if you are giving certain medication which has antimuscarinic effect, and if you suddenly stop that and introduce cariprazine, there may be nausea, vomiting, malaise. Hence, my dear friends, you need to remember this dopaminergic rebound risk, antihistaminic rebound risk, antimuscarinic rebound risk. Hence, we have to be very careful when we cross taper. And you should not confuse with cariprazine side effect. So, clinical rule, please remember, do not mistake the legacy drug withdrawal. That means the drug which is already been given for cariprazine-induced side effect. Because both may overlap and sudden stoppage or titration is done in a very haphazard manner can cause various problems. Hence, there is a switching protocol for cariprazine. You can see here the old antipsychotic is given first. And once the old antipsychotic, imagine you are giving risperidone 8 mg and there is no improvement. Along with 8 mg, you have to give cariprazine, my dear friend, together. Once you reach the cariprazine at the effective dosage, both medication should be there over a period of 2 to 3 weeks, invariably 3 to 4 weeks. That is called as plateau switching protocol. Both medication at the full dosage. Once the cariprazine starts acting, that is at the end of 3 to 4 weeks, start tapering the old antipsychotics. That is called as plateau switching protocol, my dear friend. You need to continue the old antipsychotics in the full dosage and add cariprazine for the full effective dosage. Continue both. Once you reach 1 month of both the medication, then only you taper the antipsychotic. By doing this, you will decrease the rebound side effect, my dear friends. So invariably, both the medication should be at least for 3 weeks in a full dosage. Don't do cross tapering. Tapering should be done once the cariprazine as effective dosage is reached. Hence, there is a legacy switch matrix, my dear friend, especially in medications like aripiprazole, brexpiprazole, which is a partial agonist. you can do cross tapering within 1 week without any major side effect, because aripiprazole doesn't have any H1 or M1 or D2 blockade. Hence, aripiprazole, brexpiprazole, you do direct cross tapering or stop aripiprazole today, start tomorrow cariprazine. No major problem. Suppose if you are giving D2 blockade such as risperidone, haliperidol, paliperidone, then you need to go for plateau switching mechanism. That means at least 3 weeks full dosage of both the medication should be given. Then only you need to taper the older medication after 3 weeks. Slow switching, especially if you are giving olanzapine, quetiapine, clozapine, which has higher affinity towards antihistaminic, antimuscarinic, dopaminergic. In such a scenario, take 4 weeks both the dosage and slowly taper the first dosage. So you can do fast switching in aripiprazole and brexpiprazole, which has partial agonist. In D2 blockade, take 3 weeks. In slow switch, go up to 4 to 6 weeks, my dear friend. Now let's understand about the drug interaction. Especially, cariprazine is metabolized by CYP3A4. If there is a drug which inhibits, like ketoconazole, delitazam, erythromycin and grape juice, in such a scenario, this clogs the hepatic. By clogging the hepatic, it increases the effect of cariprazine. That means you need to reduce the dosage of cariprazine now. If the patient is taking grape juice, please tell them you have to reduce the dosage. If the patient is on erythromycin, diltiazem or ketoconazole, you have to reduce by 50%. Suppose the patient is on CYP3A4 inducer, my dear friend. What is an inducer? Which induces the enzyme like carbamazepine, modafinil, St. John's, what? That accelerates the metabolism of cariprazine. In such a scenario, monitor closely and give the highest dosage, that is up to 6 to 9 milligram can be given. But it is based on individual basis. So this is about cariprazine. To conclude, it is considered as the third partial agonist apart from aripiprazole and brexpiprazole. It is historically distinguished by its significant higher selectivity and affinity towards dopamine D3 receptor. Its affinity is so much more than the dopamine, endogenous dopamine. Hence, it dislodges the dopamine and occupies the dopamine D3 receptor. This preferential partial and agonism towards D3 receptor improves functional recovery, improves delusions and hallucination. The patient will recover. Not only that, it causes low craving since D3 receptors are there in the nucleus accumbens, ventral tegmental area, limbic system. Hence, it decreases substance craving. Further, it acts on negative symptoms. So, especially in first episode psychosis, cariprazine can be given, especially in young patients, my dear friends, who are highly sensitive for metabolic changes. You can consider. Further, if the patient has predominant negative symptoms, choose cariprazine, my dear friends. If the patient has comorbid substance use, again, choose cariprazine. So, my dear friends, since D3 receptors are highly prioritized, negative symptoms, cariprazine is the best. If the patient has apathy, alogia, social withdrawal, choose cariprazine. If the patient has a tendency to miss the medication, cariprazine is considered to be oral depot. Simple reason is cariprazine, one of the metabolite, dysmethyl cariprazine works up to 3 to 4 weeks, my dear friend. And over a period of time, it accumulates. Hence, it is considered as a oral depot. But however, once you are cross-tapering from one medication to cariprazine, you have to manage the cross-tapering very carefully. Otherwise, you may see dopaminergic rebound, histaminergic rebound, serotonergic rebound. So you have to be very careful. Further, if the patient has family history of diabetes, obesity, weight gain, cariprazine is a drug of choice. So cariprazine is a trans-diagnostic medication, not only in schizophrenia, bipolar, and depression. It has found to be in autism spectrum disorder, in children, it has been found, and nowadays it has been explored in other psychotic disorders, and other psychiatric indication. However, it has a long half-life, 3 to 4 weeks, with one of the metabolite, that is DDCAR. So you have to watch and also look for the drug interaction with CYP3A4 enzymes. So it is also useful in pediatrics, and it has been found to be useful in treatment-resistant schizophrenia and substance comorbidity. So being a transdiagnostic, keeping a vigilance on the half-life, and it can be used as a broad spectrum antipsychotic. So Cariprazine, used from the dosage of 1.5 to 6 milligram, is a wonderful drug. It is considered to be a broad spectrum antipsychotic, my dear friend, has antidepressant activity and also anti-craving agent. So Cariprazine is a atypical molecule in atypical antipsychotics, my dear friend. Thank you very much for giving your valuable time. Stay safe.